Good afternoon, everyone. On this rainy day in Washington, D.C., I'm Jenny LeRae, Vice President for Strategy and Communications at Research America, and welcome to our Alliance member webinar with Dr. Peter Hotez. Just a couple of housekeeping items. Please type your questions into the question box at any time. We'll save questions for the end for our moderator to read. And for those of you dialing in by phone, we'll open up the lines after Dr. Hotez's presentation, and you can simply hit *6 to unmute your line and ask a question. Our speaker today is Dr. Peter Hotez, renowned infectious disease expert and physician scientist with many positions and accomplishments, but suffice to say he is the Dean of the National School of Tropical Medicine at Baylor College of Medicine, and he co-directs the Texas Children's Center for Vaccine Development. Peter, it is so terrific for you to join us. Thank you for extending your time with us to a full hour. We know how busy you are, not only with your own research, which we'll hear about shortly, but the terrific media you've been doing day in and day out to provide such clear and compelling information to the public. I am now going to hand the screen over to you.
Well, thank you so much, Jenny. It's a real honor to do anything to be linked to Research America. I can't think of a more important organization in Washington, D.C., except maybe the NIH. And you've done such path-breaking work and advocacy, and you guys are my role model for how to do advocacy around science, which of course is more important than ever. You know, I think if there's any silver lining to this COVID-19 disaster, and it really is a disaster, is the fact that I think people are now hearing from scientists at an unprecedented level compared to the past, and hearing from scientists unfiltered. And I think that's going to be really important for us, because one of the things that I've spoken about at Research America over the years is the fact that scientists too often are invisible, that the American public doesn't have a good sense of what scientists does, and that has had an enabling effect for anti-science movements like the anti-vaccine movement that I've had to go up against over the years. And so today what I'm going to do is talk about kind of a 30,000-foot aerial view of where I see global health going. That's one of my passions. I developed vaccines for neglected tropical diseases. And then about 10 years ago, we added to that portfolio a coronavirus vaccine program. But I didn't want to only talk about our coronavirus vaccine program. I wanted to put it in this context of a larger, bigger picture. And the other thing I like to do is I like to write books. The last one was called, that Research America was really helpful in making people aware of, was called Vaccines Did Not Cause Rachel's Autism, about my daughter Rachel and why vaccines don't cause autism. But this is the title of the next book, which will be published by Johns Hopkins University Press again. That'll come out at the end of either this year, probably the beginning of next year. That's very relevant to our current situation. It's called Preventing the Next Pandemic, Vaccine Diplomacy in a Time of Anti-Science. So Jenny, are you doing the slides, or is somebody doing the slides? I'll just say go to the next slide, please. I guess we'll do it that way. And it starts out with a good news part of the story, which is that vaccines have been incredibly successful. What happened was, in the year 2000, the Millennium Development Goals were launched, and with that actually more or less signaled the start of the Bill and Melinda Gates Foundation. And one of the big tranches of money that the Gates Foundation provided was to start the organization you see at the bottom there, the old logo and the new logo, which is the Gavi Alliance. Now we just call it Gavi. The Vaccine Alliance originally stood for the Global Alliance for Vaccines and Immunization. And I think it's one of the most successful global health programs ever launched. And that the idea was to expand the use of existing vaccines like the vaccines for measles, pertussis, tetanus, Haemophilus influenza, and diphtheria, while simultaneously introducing 2 new vaccines for pneumococcal disease and rotavirus infection. And this, by all measures, has been an extraordinarily successful undertaking. Here are some, we've all heard about the IHME models. The other thing IHME has been doing is monitoring progress for some of these big global health problems. And you can see that it's resulted in big dramatic reductions in the number of kids dying every year from measles, from 500,000 kids dying to under 100,000. Similar gains in pertussis and tetanus and Haemophilus influenza type B and diphtheria. And on the right-hand slide, it just shows some pictures from my favorite black and white photographer, Sebastião Salgado, does these amazing images of people being photographed of getting their vaccines. He did this for a commemorative exhibit for the World Health Organization and the Pan American Health Organization. Next slide. My own experience, my own personal experience goes something like this. Back in the 1980s, I was a pediatric house officer at Mass General, and I was admitting a child every few weeks with Haemophilus influenza type B meningitis, Hib meningitis. And at that time, the house officers were required, the residents were required to do the lumbar punctures and look at the cerebral spinal fluid under the microscope. And when you did that, this is what you would see: polymorphonuclear leukocytes and gram-negative organisms, and your heart sank as you knew there was a high likelihood that that child was going to not do well with Hib meningitis. And what you can see on the left is the timeline for when the incidence of Hib meningitis, and then the timelines of when new vaccines were introduced. And the first 2 vaccines that were introduced, those first 2 arrows, were new vaccines, but they were not effective at immunizing infants against the infection. And then the last arrow was when John Robbins and Raquel Schneerson at the NIH and David Smith and Porter Anderson in Rochester and Boston figured out you could modify the vaccine by binding it to protein, taking the Haemophilus influenza type B capsule, binding it to protein, and then it was effective in immunizing infants. And you could see what happened. The vaccine completely disappeared. So this was a disease that I went admitting kids every couple of weeks with at Mass General to by the time I was a junior faculty member at Yale. It was a disease I pretty much spoke about in terms of his historic interest only. So it really goes to show you the power of what a vaccine can do. The other thing I like showing the slides, and I've been talking about it in the context of COVID, you know, you've been hearing about this race for a COVID vaccine, and I've been trying to put some perspective on that by saying, you know, there may be a race, but the first vaccine is often not our best vaccine, and Hib is a good example. In fact, for most of our vaccines, the first vaccine is not our best vaccine. They get refined and improved upon, so that the first set of COVID vaccines that come out, expect them to undergo revisions and improvements in subsequent years, so that maybe one day we'll be at a situation like Haemophilus influenza type B meningitis. On the next slide. And the success has continued. This is the consequence of the global elimination of diseases like polio, where through the Global Polio Eradication Initiative, which is through the WHO and UNICEF and Gavi and the Rotarians and Rotary Club and of course the Gates Foundation, we've seen this dramatic decrease in going from 125 countries endemic with polio down to 2 or 3, and that's been really gratifying to see that. And even for measles, we've seen enormous progress in eliminating measles based on the number I showed you previously. And that's quite an accomplishment given the fact how contagious measles is. And by now, anyone watching cable news on a regular basis has heard about the reproductive number, the R0. Refers to the number of people infected if a single individual has the disease. And you can see that the R0 of measles is pretty impressive between 12 and 18. And what that means, practically speaking, is if a single individual has measles, 12 to 18 others will get it. So the fact that we can even talk about eliminating measles means that we're vaccinating more than 95% of the world's population. On the next slide. Now that's the good news, and part of the book is a premise of the new book is to say all of those great global health gains that we've had since 2000 are now, for reasons that we're still trying to understand, are slowing, or in some cases halting, or in some cases even reversing. But it's not happening globally. It's happening in certain hotspot areas that are kind of highlighted in blue there, and they tend to be in areas where that I describe in white there, where political instability combines with climate change, urbanization, deforestation, or anti-science movements. And they're particularly true of vaccine-preventable diseases, as well as this other group of infections that I didn't really introduce because of time constraints, called the neglected tropical diseases, or NTDs, which are chronic debilitating infections that I've devoted a good part of my life to. And so and to make this sort of clearer, and it's still not an entirely full-baked idea, I thought I would go through just quickly a couple of case studies, go to some of those examples of those circles in blue on the next slide. So one of the areas is the Arabian Peninsula, where we've seen a sharp rise in both vaccine-preventable diseases as well as neglected diseases. And on the Arabian Peninsula, particularly in countries such as Syria and Iraq and Yemen, we've seen a sharp increase in these diseases. And I got involved in this because during the Obama administration, I served as a US science envoy focusing on and providing access to vaccines in this part of the world. And the top picture there is of a kid with cutaneous leishmaniasis. It's a disease transmitted by sandflies that inoculates a parasite. It's not a killer disease, but it causes terrible disfigurement. And we've seen now with the collapse of the health system infrastructure on the Arabian Peninsula, hundreds of thousands of cases there. So it's an example of how war and political collapse could contribute to it. But the other thing that fewer people realize is the other thing that's been happening on the Arabian Peninsula is climate change. We've been seeing temperatures of 50 degrees Celsius or more. In fact, there's a celebrated article called Halfway to Boiling to make that point. And this is destroying ancient agricultural lands, creating food insecurity, and driving people into cities. And some people feel that was even a stimulus for all of the terrible things that have happened on the Arabian Peninsula over the last few years in terms of the ISIS occupation, that it was actually linked to food insecurity and climate change. And then, of course, we have this Saudi-Iran proxy war going on in Yemen in the middle panel, which is also causing thousands of deaths from cholera, as well as cases of leishmaniasis and the return of vaccine-preventable disease. And then through the annual Hajj pilgrimage and Umrah, we're starting to see introduction of new diseases. We've heard about now the interruption of that because of COVID-19, but even a few years before, we've seen the introduction of dengue, and now you have Aedes aegypti mosquitoes and dengue on the Arabian Peninsula. Another example is in Venezuela on the right-hand side, where with the Maduro regime, first Chavez and Maduro, there's been a collapse in the financial infrastructure, halting of vaccination programs, and the return of measles. And this has been well documented by PAHO, the Pan American Health Organization. And we're seeing that play out with the return of measles in Venezuela. And now there's the measles map up on the upper right there, and you can see how it literally looks like it's spilling over now into the Amazon rainforest and into across the border in Colombia, where it's affecting indigenous populations, including the Wayu on the Venezuela border with Colombia, as well as the Yanomami Indians, which is causing Native American populations, which is causing devastation and decimation of those populations from measles. And now we're starting to hear about it from COVID, tragically. The other thing that's happening as employment is dried up, people are now retreating into areas where there's illegal mining. And these are immunologically naive people who are now seeing malaria for the first time. So we're seeing a sharp increase in malaria among the miners. In fact, and that's what the middle panel is, one of the so-called malaria mines, as they're called, where there's been a 400% increase in malaria. And it goes on. On the next slide, this is what we're seeing in parts of sub-Saharan Africa. Jeffrey Gettleman of the New York Times has used this term, the Africa's unwars, to describe the fact that they're not conventional warfare between warring factions as in the past, but really banditry on civilian populations and predation on civilian populations by Boko Haram on the top there, and what we're seeing in DR Congo, which again is collapsing health systems and bringing back vaccine preventable diseases and neglected tropical diseases. Now you might say, well, why the heck do I have Texas and the Gulf Coast in the same context? Well, what we're seeing again is not so much war and political collapse, but climate change and urbanization, together with anti-science. And Texas is in some ways the home of the anti-vaccine movement in America, where we work, and we're seeing a sharp increase in both vaccine preventable diseases as well as neglected diseases like Chagas disease and typhus, dengue, and many others. So this confluence of social determinants and climate change is not unique to what we ordinarily think of low and middle income countries, but even places like Texas. And if you go to the next slide, and along with that has been this shift in poverty-related diseases globally. And it's a phenomenon that we're still trying to get our arms around. I've written about this in a book a couple of years back called Blue Marble Health. And it has the following premise, and that is when you add up where all the poverty-related neglected diseases are, which would include AIDS, malaria, TB, but also the neglected tropical diseases, they're not only found in the most devastated countries of places like Central African Republic or South Sudan or DR Congo. On a numbers basis, they're surprisingly common among the G20 economies, the group of 20 economies representing the most common, the leading economies of the world, as well as Nigeria, which is not a G20 country, but it has a GDP greater than the bottom 3 or 4 G20 countries. So that it's, even though the G20 economies account for 86 to 90% of the global economy, it's the poor living among the wealthy that are increasingly accounting for these diseases. And so it tries to make the case, and it's an idea that by no means has caught on yet, but it's something that we're looking more and more into, that rather than saying it's a difference between developed versus developing countries, what we're seeing is it's the poor living among the wealthy in the G20 economies that are accounting for these diseases. So the G20 economies now account for most of the world's worm infections, leishmaniasis, Chagas disease, tuberculosis, dengue, leprosy, and the list goes on. And on the next slide, and along the same vein, so far we're seeing COVID-19 mostly among the G20 nations now, accounting for over 3 million cases. But one of the things that we're seeing play out in a very Blue Marble Health fashion is the fact that it's people living in poverty are often disproportionately affected. So here in Texas, in Houston, and also in New Orleans, it's people who live in poor neighborhoods, and especially African American, Hispanic American, and now Native American minority groups that are being disproportionately affected. We're now learning about the devastation among Navajo populations in the southwestern US. So it's very much along that same lens of Blue Marble Health. And now Johns Hopkins University Press is planning on issuing sort of a COVID instant book version of the Blue Marble Health book that I hope will come out in a couple of weeks. And the next slide. So just a few words about COVID-19. It's behaving in ways that I've not really seen from coronaviruses, and we're starting to hear stories now from the docs and working in the ICUs and the New York hospitals at Bellevue, at NYU, at Cornell, and Brookdale, and the list goes on, how there seems a really interesting phenomenon, very worrisome phenomenon, and that it's not just a matter of pulmonary disease that we're seeing with this, it's also severe heart disease, sudden death, strokes, coagulopathies, as well as high rates of disease among people with obesity. And I'm trying to understand if there's any unifying theme to this. And there's this interesting graphic that we have found looking, and there's the reference to it below, where the ACE2 receptors are. And one of the things we know about the SARS-2 coronavirus that causes this is it binds very tightly to ACE2 receptors. And it occurred to me that a lot of these very odd clinical sequelae may indeed be a consequence of that tight binding to the ACE2 receptors, which are found in the tissues I list above. And maybe that might turn out to be a unifying theme. No evidence for that yet, but I think it's something we're very interested in exploring. On the next slide. So there's now an aggressive effort to develop vaccines now for the SARS-2 vaccine, and most of the vaccine approaches you can understand from looking at that picture in the upper right there, which is, we've all by now seen cartoons of coronaviruses that look like donuts with RNA filling up the middle of the donut, and then there are these spikes coming out of it, and that spikes are the S protein that binds with the host receptor. And it turns out most of the vaccines under development are involved in creating an immune response to the COVID-19 virus, to the SARS-2 virus, to prevent binding of the virus to host receptors. And then it's a matter of figuring out which technology might be the best in inducing that protective response against the spike protein. And on the left-hand side is a slide from Tony Fauci, from Dr. Anthony Fauci, listing the major platform technologies now involved in COVID-19 vaccine development. But the basic idea is all of them are more or less working by inducing immunity to the spike protein, or a component called the receptor binding domain. So that recombinant protein, one listed there is ours, that's being developed at Baylor and Texas Children's. There's nanoparticle vaccines. We've heard a lot about the DNA and RNA vaccines, and some of the companies involved with those, virus vectored vaccines, and even live attenuated vaccines. On the next slide. So one of the things that we're doing to address all of these poverty-related neglected diseases arising in places like Venezuela and the Arabian Peninsula and in Africa and elsewhere is trying to develop vaccines for them, which includes the COVID-19 vaccine, but others as well. And I like to say that we try to develop the vaccines no one else is attempting, because they're mostly for poverty-related diseases. So about a decade ago, we moved to Baylor College of Medicine to set up this National School of Tropical Medicine, together with a vaccine center at Texas Children's Hospital. And that's a picture just of Texas Children's Hospital in the Texas Medical Center. And it's co-directed, so I'm the dean of the school, but for the vaccine center, I co-direct that with the woman on the lower left there. That's Mary Elena Bottazzi, and we've been science partners for more than 20 years, and really trying to pioneer this concept of how you can develop vaccines in the nonprofit sector. On the next slide. So it's called the Texas Children's Center for Vaccine Development, CVD, and we got the idea of calling it CVD, named after one of my friends and heroes, Mike Levine, who's been running the University of Maryland CVD forever, and now being taken over under the able leadership of Kathy Newsel. And the approach is to develop low-cost global health vaccines, mostly recombinant protein vaccines, where we actually do the technology transfer to low and middle income countries. So we're building vaccine development capacity in parallel. And there's a portfolio of our major vaccines that we have in various stages of product and clinical development for schistosomiasis and hookworm and river onchocerciasis is river blindness, leishmaniasis, Chagas disease, and then those coronavirus infections, which include SARS and MERS and now SARS-2. Now, on the next slide, you might say, well, how does COVID-19 or how do coronaviruses fit in with neglected diseases? Well, what we're now starting to see is COVID-19 is not only now a problem of Europe and the US, it's now starting to race into other parts of the world. We're hearing terrible stories in Ecuador now, in Guayaquil, about how bodies are being piling up in the streets, and especially in the crowded urban slums of Latin American cities. We're hearing now about a big, sharp increase in Fortaleza and Belém, in Manaus in northern Brazil, even in Rio. And I think this is going to be one of the next big waves. Now that the virus is going to start moving into the southern hemisphere, we're hearing about big upticks in Mumbai and India and other Indian cities. I'm worried about Lagos. I'm worried about Dhaka and Bangladesh. And you know, we're now taking our low-cost global health approach for vaccines and hopefully going to have a role on global health vaccines for COVID-19. On the next slide. So we just announced yesterday our partnership for a global coronavirus vaccine initiative, and on the bottom are some of the institutions we've been working with for a long time: Walter Reed and UTMB and Galveston and New York Blood Center, supported by NIH. And now we've announced our new partnership with PATH, which is a renowned product development partnership based in Seattle that led the development and licensure of the meningococcal A vaccine for Africa and the malaria vaccine. And now we're partnering with them for our global coronavirus vaccine. And now we're really trying to look at this concept of, okay, we're going to get through the early stages of vaccine development for all of our vaccines. How are we going to scale them up? And we're very much taken with this idea that I really tried to push hard on when I was U.S. Science Envoy of vaccine diplomacy, and that is nations putting aside their ideologies to work together in order to make life-saving vaccines. And the idea was inspired when I was president of the Sabin Vaccine Institute, and I first heard from Heloisa Sabin, Albert Sabin's widow, about Albert's efforts to work with Soviet scientists at the height of the Cold War to develop vaccines, and how both Soviet scientists and the US scientists put aside their ideologies to work together on life-saving vaccines. And that's what I've been trying to do in the Middle East and elsewhere, and with other Muslim majority countries. And that's going to be, I think, an important theme if we're really serious about developing global vaccines for diseases like COVID. On the next slide. Now, one of the other big forces that's going to be working against us beyond war, political collapse, and climate change and urbanization, if that weren't bad enough, we have this problem of anti-science. And unfortunately, the anti-science movements are very strong in the United States. And we're already seeing this now play out against social distancing. And you're seeing, unfortunately, in my state and others, big demonstrations and trying to go after prominent scientists, including Dr. Fauci, but they've also been going after me and others. And we're seeing, and the way these protests are playing out, I'm finding it very ominous. We're already seeing in Michigan these anti-science movements against vaccines, including COVID-19 vaccines, has been accompanied by individuals parading around wearing camouflage and holding rifles in a very menacing type of way. And this is a culmination, I think, of something that we've been following for a number of years. On the next slide. This problem of this anti-science movement, which is sometimes known as the anti-vax or the anti-vaccine movement, what the World Health Organization first identified a year ago as one of the top 10 global health threats, calling it vaccine hesitancy. And it began really in response to declines in measles vaccination coverage, because it was alleged that the MMR vaccine causes autism. And we started to see this gain ascendancy with measles in 2018, with more than 80,000 measles cases in Europe. Then it expanded to 100,000 measles cases in 2019. And it was really built on 20 years of declines in vaccination coverage for measles that began on the next slide with this fake paper in the Lancet written by Andrew Wakefield and his colleagues, claiming that the measles, mumps, rubella vaccine has the ability to cause what was then called pervasive developmental disorder. Now we call it autism. It was ultimately retracted by the Lancet, but it took 12 years to get retracted, and that gave a lot of momentum to the anti-vaccine movement that's now been taking off in the US. And next slide. It's particularly bad in Texas, where we've seen now more than 60,000 kids denied access to their vaccines. And it's been particularly bad in the Austin area for reasons that we can talk about. And we don't even know about the homeschooled kids. And what's happened in Texas, which is pretty odd, is it's become very politicized since 2015. It's linked itself to the far right wing of the Republican Party, the Tea Party, and a lot of that is involved in language, libertarian language, saying you can't tell us what to do with our kids. There's this concept they promote called medical freedom or health freedom, and now it's been tied to the protests around social distancing. So this is going to be a more and more worrisome trend that we're going to have to follow. On the next slide. Based on what we saw happening in Texas, I worked with a medical student, Jackie Olive. You know, where we weren't funded to do this, together with two of our faculty, we started seeing if these sharp declines in vaccine coverage are unique to Texas. And we identified a number of hotspot areas where we might predict that vaccine hesitancy could lead to measles epidemics. And sure enough, we have seen measles epidemics last year in about half of them. And we are starting to see the return of measles to the United States. So as bad as things are with COVID-19, it may not stay restricted to COVID-19. Now we have to contend with measles, as well as declines in influenza vaccine coverage. On the next slide. So I'm quite worried about this four-headed anti-vax monster. A lot of the anti-vaccine activities are been reorganized now under RFK Jr., Robert F. Kennedy Jr., who's started this organization, which has the unfortunate name of Children's Health Defense, in 2018. And they've been very active and very aggressive, including a lot of aggression towards me personally, you know, putting out a lot of fake information about vaccine scientists, including me. It turns out they think I'm making millions of dollars for our schistosomiasis vaccine, which my wife answers, if only that were the case. But unfortunately, no dollars so far, and no hope that we will. And so here are the four components that I'm seeing of the anti-vaccine movement. I'm seeing a prominent media component now of 480 fake anti-vaccine misinformation websites out there, including, you know, Amazon. I mean, you can go to the Amazon website now, and you can do this right now on your computer. You put books up at the top, and then you'll get a scroll down menu at the left that has health, wellness, and dieting. You click on that, you get vaccinations. You click on that, and you'll get all fake anti-vaccine books. So Amazon is now the single largest promoter of fake anti-vaccine books. And then there's this political machine where they've created political action groups like Texans for Vaccine Choice have started in most states now. Not all, many are linked to sort of the far right wing of the Republican Party and get money from donors that typically give to Tea Party causes and issues. And then there's sort of this, what I call deliberate predation focusing on specific groups. Originally, it was the Somali immigrant community in 2017 that led to a terrible measles epidemic, then the Orthodox Jewish community last year, and now you're starting to see, and with very inflammatory images and language like these fake yellow Jewish stars, which are extremely offensive. And then we're also now seeing this moving to the African American community, where again they're calling vaccines the next Tuskegee experiment, really inflammatory stuff. And then the last one, the war on women, they're targeting the HPV vaccine specifically, saying it causes teenage suicide and depression, and this is leading to big declines in HPV vaccine coverage, really denying a generation of cancer prevention to women across the country. So, unnecessary cases of cervical cancer, as opposed to Australia, which has announced they're going to eliminate cervical cancer by the year 2030. On the next slide. So this is one of the reasons I got involved with fighting the anti-vaccine movement, because I'm a vaccine scientist and pediatrician, but I also have a daughter with autism and wrote this book called Vaccines Did Not Cause Rachel's Autism, which goes into the science, explaining on why there's no link between vaccines and autism, why there's no plausibility for it, because we've learned so much through the science funded by NIH about how autism begins in early fetal brain development through the action of more than 100 genes. And now we've done whole exome sequencing on Rachel at Baylor Genetics and been able to identify a new autism gene that bears some resemblance to the neuronal cytoskeleton genes are already published. On the next slide. And again, I blame a lot of the anti-vaccine movements to the fact that historically scientists have been so invisible up until recently. And I don't have a lot of evidence to support that, but I go back to this slide that Research America published a couple of years back, and it would be great if they were to update it, because I think things will be better now with all the people tuning into COVID-19 information on the cable news networks. But back a couple of years ago, they found that the vast majority of Americans cannot name a living scientist. Even if they could, it was individuals like Neil deGrasse Tyson or Bill Nye, great people, but not working scientists as we know them, that are struggling over grant applications and lab meetings and doing major revisions on papers. And on the right there is a study showing the vast majority of Americans, scientists, are not out there on social media blogging about their science. So there is that invisibility factor that I think has been very enabling. On the next slide. So I'll end there to say that the way I see this working out in terms of the future of disease and global health is going to be a bit of an epic struggle. It's on the one hand, we're seeing great progress through vaccines and new biologicals, including potentially new COVID vaccines, mass treatment, vector control strategies, but then we're still going to have to contend with these very dominant 21st century forces, including poverty, climate change, war and political collapse, and urbanization. And we'll see, which of these is going to win out. I hope it's the ones on the left, but happy to, stop there and see if we have time for a few questions, Jenny. And thank you again for the opportunity.
Thank you, Peter. We do indeed have time for questions. I mean, thank you. What a tremendously content-rich, important, and sobering presentation. I'm going to ask you a question, getting into this topic of visibility of scientists, and how do we encourage that? And what have you learned? You are one of those scientists who has tens of thousands of people on your Twitter feed, and you make a lot of public appearances in mainstream media. What have you learned as sort of key tips for scientists who want to be able to communicate clearly to the American public?
Well, thanks for that. And it's something I've tried, and sometimes I don't really quite know what I do, but it seems to be working. A couple of things along those lines. The nicest compliment, the one that resonated with me, was given by one of my editors at Johns Hopkins Press, who said, Peter, you have this knack for being able to explain have an act to complain as well, but an act to explain complex scientific concepts without dumbing it down, without seeming condescending, without making people feel like you're talking down to them. And I think that's the key, right? You need time to be able to explain complex scientific concepts. And I think what's out there, there's a lot of people who specialize in communications who think you have to dumb it down, who think, you have to really simplify it. And I push back on that. I say, no, I think the American people are smart enough to understand complex concepts, but you have to give it a little time. You have to not use a lot of jargon. And if you're willing to do that, people get it and people like it and people understand it better. So one of the things that I try to do, when I'm on, whatever it is, Fox News or MSNBC or CNN, is it's not easy going from Fox News to CNN or NBC, is to explain why I came up with the things that I say. And I think that's been the weakness of some of the White House coronavirus task force briefings, is that they'll throw numbers out there without taking the time to explain how they derive the numbers, where they came from, which is something that I'll do, and that's often quite appreciated. And the hard part is getting the interview time to do it, because sometimes you only get a 2-minute hit or a 3-minute hit, and now I've got, the networks are willing to give me a little more time, and I need that time to explain what I'm thinking. And the other thing I do is I try to personalize it. I give it, and I say it's a very personal perspective, and I'll interweave it with stories about either my family or people I know or my past training. And some people are annoyed by it, but others like it because people need to be able to identify with scientists. People need to be able to have a face that goes along with it. And I think that also seems to resonate. It also resonates with people in the UK, which is kind of interesting.
Terrific. Well, I'm going to turn it over to Terry. I think we have some questions in our question box.
That's correct. Thank you so much, Dr. Hotez. One question coming in, with all the various and disparate vaccine development efforts going on across the globe, how can we ensure efficient collaboration within the research community, specifically related especially to patient recruitment for clinical trials?
Yeah, I mean, there's a lot of problems with the communication strategy, and I've pointed this out to the scientific leaders in this country, including NIH, and they totally get it. So that's a work in progress. So we need to have a little more robust communication around vaccines, because there's a lot of language coming out there that confuses people, especially when they say they're going to have a vaccine by the fall. They're not going to have a vaccine by the fall. There's no way you're going to collect enough efficacy data and safety data to have that. And I think part of the problem is I think the White House is very focused on the manufacturing strategy and how we're going to scale up manufacturing, and basically taking lessons learned from making ventilators and making diagnostic kits and applying that to vaccines. And now we're really stressing the importance of understanding what it means to go through a phase 1, phase 2, and phase 3 clinical trial, and why it takes time to collect all that efficacy and safety data. And I think that's what you're going to see come out next. Regarding international cooperation, yeah, that has been challenging. I also think there's been misunderstanding there, because there was a big announcement earlier this week about CEPI and WHO and this big global initiative that the United States is not part of. And people just assume that must be something coming out of the Trump administration. I say, well, not entirely, because one of the reasons why the U.S. is not necessarily linked up with CEPI and others in the past is because the U.S. is already the largest funder of global health technologies. I mean, if you ever look at the G-Finder report, which is this organization called Policy Cures out of Australia, where they track the public spending on global health technologies, many people are surprised to learn overwhelmingly the U.S. is by far the largest funder of global health technologies, and almost all of that's from NIH, and almost all of that is from NIAID, to the tune of about $1 billion a year. And then much further down is the UK, and the European Union. And the big problem is we're not getting the other G20 countries to step up. But the US, overwhelmingly through NIH, is the largest funder of global health technology, far more, for instance, than even the Gates Foundation. I think it's important for people to realize that what our footprint is in global health already.
Terry, I believe we have some additional questions.
We sure do. Here's a question from a Sabin Vaccine Institute alum who says, "Hi, Peter," from Emily Conran.
Hi, Emily.
Which is now working on global health R&D advocacy, recognizing the long timeline of vaccine development and the fact that the first vaccine, like you said, is unlikely to be the best. How can we encourage Congress to make bold but patient and long-term investments in vaccine research and development, both for COVID-19 and future threats?
Well, hopefully the urgency that everyone is seeing around COVID-19 will translate into bigger investments for global health vaccines. On the other hand, I said that after SARS in 2003, and then I said it again after H1N1 in 2009. I said it again after MERS in 2012. I said it after Ebola in 2014, and I said it again after Zika in 2016. But I think this one will clearly resonate with Congress, and that it's extremely complicated to accelerate a new vaccine in the middle of a pandemic caused by a new pathogen. It's not something we have a lot of experience with. We were somewhat successful with Ebola, which, by the way, was an amazing success story. So that would be another way, Emily, is to really catalog our successes. I mean, that Ebola story is, I think, one of the most important global health stories never told. How NIH-funded research and work of BARDA and Public Health Canada as well, which was involved in a lot of the R&D, and then Merck and Company coming together with the WHO and Gavi and UNICEF and the MSF and the Wellcome Trust, and think of what was done. That vaccine was accelerated in the VSV vaccine, accelerated in clinical trials of over 200,000 people under some of the most horrendous circumstances imaginable, war and political collapse in the DR Congo, in the death of some vaccinators and healthcare workers, ultimately shown to be over 90% protective and safe. And that basically prevented Ebola epidemic that would have easily dwarfed the one in 2014 in West Africa, would have destabilized the African continent. I think it's one of the greatest public health stories that's not yet been told, and we've got to continue to tell stories like that, or what's going on now with COVID-19, and I think we will see a sea change in that.
Thank you, Peter. Another question, which kind of builds on that, from our own Mary Woolley. If you could speak a little more about the implications of people hearing so much more about science in real time from scientists, how can we use all this attention to science to help stand down what you told us about the anti-vax monster?
Yeah, I think now is the time that we need to really recognize that it's a problem. I think we have some great vaccine organizations, advocacy organizations out there, like Sabin, like Vaccinate Your Family, like the Immunization Partnership. Now I've done it. When you go down a rabbit hole, start naming names, then you forget to name the other names. So please forgive me. But we have got a good base of organizations advocating for vaccines. But now I think is the time to really get the scientists out there, and now we've already seen how much of a difference it can make when you actually hear from actual scientists on the cable networks and the network news. How should we leverage that? Well, I think a few things. One, I think you're going to see this next generation of young scientists really excited by this and really want opportunities to do the public engagement. I would love to see, for instance, Mary, a Research America initiative that builds in public engagement, science training for PhDs and postdoctoral fellows, or even medical students. If you build it, they'll come. If you were to create content on how to do public engagement, and they'll get interested. I know this because whenever I, before COVID-19, giving grand rounds lectures or speaking to groups of PhD students, they'll come up to me, hey, Dr. Hotez, I'm all in. How do we do it? And the problem is we don't have the infrastructure in place. The other thing we have to fix is the ecosystem for it, because, when I was getting my training and my MD and PhD, the message was, no, you don't engage the public. That's seen as a form of grandstanding or self-promotion. And we got to get beyond that, because I think what happened was nobody said anything. And the consequence was it was just a handful of organizations like Research America and some of the others that I've named, and not hearing from the scientists themselves, other than what Research America and others were putting on, what, had a detrimental effect. And now we've got to fix that. And what that means is academic department chairs and deans, now that I'm a dean, I've gone over to the dark side, have to figure out a way to encourage promoting science in the public domain as an important activity. Because I think a lot of academic health center office of communications don't really, maybe changing now, but traditionally haven't liked their docs and scientists out there. They want to control the message. They're worried about the reputation to the institution, that if we mess up, we say something incorrect, that will have damage to the institutions. I think we've got to slowly change that culture to get department chairs, deans, and university presidents actively encouraging our scientists to be out there. And maybe this will be the event that makes it happen.
Well, what a great topic to end on. I mean, we are with you all the way on the public engagement of scientists, and I'll send you some information about a microgrant program that we've been running for 2 years with support from the Rita Allen Foundation, helping early career scientists get more involved, particularly locally. But I think we have run our course. I hope, again, Peter, thank you. What an incredible hour to spend with you. And I hope you can all join us for our next Alliance member call, which is on Monday with the Honorable Dr. Lewis Sullivan, former HHS Secretary. He will be talking about health disparities during the COVID-19 crises, among other topics. So keep an eye out for invite emails and the registration links. We welcome your suggestions for future speakers, and thank you again. Please stay in touch with us.